Greetings to all of you, my dear students. So, in this second session, I'm going to discuss something about conventional anti-epileptic drugs. So, let us see the details about it. So, we are going to discuss about the classification of anti-epileptic drugs, phenytoin, sodium, and phosphonatoin, and all the other drugs like phenobarbital and primidone, carbamazepine, oxcarbazepine, eslicarbazepine, ethosuximide, sodium valproate, divalproxy sodium, and all the other types of benzodiazepines in this session. So first, classification of anti-epileptic drugs. So there are various varieties of drugs like groups of drugs, that is barbiturates, phenobarbital, hydantoin derivatives, that is phenytoin and phosphonatoin, succinamide group, that is ethosuximide, and then deoxybarbiturates, primidone, and the immunostilbines, that is carbamazepine, oxcarbazepine, and aliphatic carboxylic acid derivatives, that is valproic acid, valproate sodium or valproic acid, and divalproates, and phenyltrizines, that is lamotrigine, and cyclic GABA analogs, that is gabapentin and pregabalin, and benzodiazepines like clonazepam, diazepam, lorazepam, clobazam, and newer drugs that we are going to discuss in the third session, that is topiramate, zonisamide, levetiracetam, gabapentin, and tiagabine, and lacosamide, and this cyclic GABA analogs also come under newer drugs only. So this we have discussed already. Classification based on the mechanism of action. So I'm not going through it again. So just to give a recap about it, I have kept this slide here. Then coming to each and every drug proper, that is phenytoin sodium. Phenytoin is the oldest non-sedative anti-epileptic drug. So remember, we will go through one drug subtopics like mechanism of action, and then pharmacokinetics, and then ADR, therapeutic uses, dose, and everything. And at the end, for the major drugs, I'm going to give a summary slide where you can get all the details. And the mnemonics also I have given somewhere. So it is the oldest non-sedative anti-epileptic drug. Lack of sedation was an advantage over barbiturate-like drugs when used for epilepsy. And it is structurally related to barbiturates, but non-sedative. Toxic doses cause CNS excitation and decerebrate rigidity, which is fatal. Mechanism of action is selectively binds to voltage-gated sodium channels in the inactive state and prolongs the inactivated state of the sodium channels by slowing its recovery, that is known as membrane stabilizing action, so that initiation as well as propagation of nerve impulses both are blocked. This we have discussed in the introductory session, mechanism of action. And at therapeutic plasma levels, this drug is very, 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 very important. And you may get essay question also. And for PGs also, this is very, very important for both the theory exam and viva. At therapeutic plasma levels, 10 to 20 micrograms per ml blocks the use-dependent sodium channels and thus inhibits the generation of repetitive action potentials. At higher doses, more than 5 to 8 times the toxic dose also reduces the calcium channels, that is voltage-gated calcium channels, and suppress repetitive firing of neurons. So that means therapeutic levels, inhibition of action potential generation, and higher doses, calcium channel inhibition, because of which further propagation or repetitive firing of neurons is inhibited. So both sodium channel and calcium channels are blocked. Whereas further higher concentrations of phenytoin also augment brain levels of GABA, 5-HT, homovanillic acid, contributing to its toxicity, and they also decrease glutamate release. Apart from that, it decreases post-tetanic potentiation, which is responsible for the spread of seizure activity. And it also inhibits the spread of seizure discharges in the brain and shortens the duration of after discharge. So these are the various mechanisms of action. Number one, therapeutic level, inhibition of action potential release, higher doses, repetitive firing is inhibited, high concentrations, other neurotransmitters enhancement, and also glutamate decrease, post-tetanic potentiation, and inhibition of the seizure discharge. So you can see delay recovery of sodium channel from inactivation, blockade in the activated state, and blocking the frequency firing, that is through calcium channel blockade. So this is neuronal membrane stabilization, inhibition of generation of action potentials, and inhibition of spread of seizures combined together, giving rise to anti-epileptic activity. Then pharmacological actions, CNS, it exerts a selective anti-epileptic action without causing drowsiness. So there is a difference between barbiturates and this one. Onset of action is slow even on IV injection, but the action persists for a considerable time after cessation of therapy. So long acting. Okay. Cardiovascular actions, anyway, cell membrane stabilizing effect on the myocardium. Then coming to the pharmacokinetics, oral absorption is slow but complete, that is 80 to 90%. IM injection, it gets precipitated in muscle and causes pain, so we don't give it. IV injection gives rise to thrombophlebitis and hypotension. And apart from that, it also gives rise to a specific manifestation, that is purple glow syndrome. P for phenytoin, P for purple glow syndrome. That is purplish black discoloration, edema, pain occurs distal to the site of injection. If we give here, so this entire upper lip will be becoming purple. It's like a glow. It's as if you have put the patient on glow. Okay, purple glow syndrome. So it is not given by IM or IV route except for fosphenytoin. So another molecule, that is fosphenytoin, that can be given. Fast IV injection of fosphenytoin gives rise to cardiovascular collapse and hence should be administered slowly. Phenytoin is extensively bound to serum albumin, so prone to displacement in hyperbilirubinemia are drugs such as warfarin or valproic acid, giving rise to toxicity. And even when there is low plasma concentration of albumin, high free concentrations of phenytoin, giving rise to toxic manifestations. Metabolized by CYP2C9 and undergoes hydroxylation and glucuronate conjugation in the liver to inactive metabolites. And it is a potent enzyme inducer, P for phenytoin and P for potent enzyme inducers, both for CYP3A4 and glucuronate transferase enzymes. And plasma half-life is about 24 hours. So 5 days are needed to attain steady state plasma levels. So we can go for loading dose at certain levels, followed by maintenance dose. Metabolites are eliminated through urine and free drug is also excreted through saliva. But this is very, very important. Pharmacokinetics of phenytoin. Its elimination is dose dependent and follows saturation kinetics or mixed order kinetics. At low doses, that is up to plasma level of 10 to 20 micrograms per ml, elimination obeys first order kinetics. You know, first order and second zero order kinetics. So its half-life of 24 hours remains constant and plasma levels do not fluctuate, as maintained stable. Okay. So when you go beyond, it's like here first order kinetics, only fraction of the drug is eliminated. But here, beyond 20 micrograms per ml, elimination follows zero order kinetics and hence a slight increase in dose results into large increase in plasma concentration leading to toxicity. That is mixed or saturation kinetics. At low level, zero order, and at high level, at low level, first order, and at high level, zero order kinetics. So when we want to increase the dose of phenytoin, we have discussed in the introductory session, we need to go for sometimes TDM so that its toxicity manifestations will be eliminated. Then phenytoin, like carbamazepine, phenobarbital, and primidone, is a major enzyme in using anti-seizure drug. It stimulates the metabolism of many co-administered anti-seizure drugs like valproic acid, tiagabine, ethosuximide, lamotrigine, topiramate, oxcarbazepine, etc., etc. That is one thing. Inducing the enzyme metabolism of other anti-epileptic drugs and also auto-induction of its own metabolism, even though it is very little less. So periodic assessment of plasma concentration and subsequent dose adjustments are needed, particularly in neonates and in patients suffering from uremia, liver disease, and hypoproteinemia. Preparations, 2 types of oral phenytoin are available in USA. That is, one is extended release pill for OD or BD use, and another is immediate release suspension or chewable tablets. And uses of phenytoin are prevention of focal seizures, generalized tonic-clonic seizures, and acute treatment of status epilepticus, these preparations. Then ADR. ADR of phenytoin, that is toxicity of phenytoin itself, is a question for postgraduate students. It's like really very vast. And even for UGs also, it can be a short question for them. ADR at therapeutic concentration, what is that? Let us see. Gingival hyperplasia or hypertrophy of gum. Whenever you administer phenytoin to patients, so it is common in children and adolescents on chronic use. So there is a possibility of hyperplasia and hypertrophy of gums with edema and bleeding. So this is because of alteration in collagen metabolism and poor oral hygiene. If oral hygiene is not maintained, then that is one reason, and another is alteration in collagen metabolism, but not related to the dose of phenytoin. So phenytoin, after being secreted through saliva, so when it gets secreted through saliva, that is very important factor for this development of this ADR. It inhibits the enzyme collagenase, which is responsible for the breakdown of collagen of connective tissue. So there is no breakdown. So because of the inhibition of the collagenase enzyme, so because of which there is overgrowth of gingival collagen fibers. Okay. So this can be prevented by maintaining good oral hygiene. Then long-term phenytoin therapy gives rise to hypertrophy of not only the gums, but also facial subcutaneous tissue, hypertrichosis, and then coarsening of facial features, otherwise known as phenytoin facies appearance. And there is a possibility of increased platelet-derived growth factors B and its mRNA from macrophages that enhance wound healing, induce gingival fibroblasts, and promote local angiogenesis. So this is gingival hyperplasia. So the other drugs which induce gingival hyperplasia manifestations are cyclosporine, calcium channel blockers like nifedipine, amlodipine, and phenobarbital. So many are there, but I have given just a few. Okay. So this can be a 2 marks question for undergraduate students and for Viva for both UGs and PGs. Then what is gum hypertrophy? Then is hypersensitivity reactions. Morbilliform skin rash, including Steven-Johnson syndrome due to idiosyncratic reaction, all sorts of hypersensitivity, that is urticarial, scarlatin film, and measles-like skin rash, accompanied by lymphadenopathy, hepatomegaly, and jaundice. Then SLE and fatal hepatic necrosis also may be seen, which is idiosyncratic phenomenon, and hirsutism in females because of increased secretion of androgens, and also acne, hyperglycemia due to inhibition of insulin release, which is to be avoided in diabetes mellitus. So if a patient comes to you with diabetes mellitus, also suffering from epilepsy, better not to choose phenytoin. It also decreases ADH release. Then hypertrichosis is seen especially in children. Hematological reactions like neutropenia, leukopenia, lymphadenopathy, otherwise known as pseudolymphoma. Vitamin K deficiency, which results in hypoproteinuria and hemorrhage in the newborn if the mother receives phenytoin during pregnancy. So the treatment is vitamin K supplementation for the treatment as well as prophylaxis. Then peripheral neuropathy on prolonged use, that is in 30% cases, it is manifested as diminished deep tendon reflexes of lower limbs. Then side effects due to enzyme induction, that is osteomalacia due to enhanced metabolism of vitamin D and also inhibition of intestinal absorption of calcium. So this is associated with, because of intestinal absorption of calcium is inhibited, it is associated with hypocalcemia. But we can't say that it is always responding with vitamin D administration. Sometimes it is not. Phenytoin also increases the metabolism of vitamin K, not only the vitamin D. So it reduces the concentration of vitamin K dependent proteins, which are necessary for normal calcium metabolism in bone. So there is a possibility of rickets in malnourished children and osteomalacia in adults. So vitamin D metabolism is inhibited and vitamin K, enhanced, and vitamin K metabolism is also enhanced. So because of which rickets in children and osteomalacia in adults. So this can be prevented by administration of vitamin D and K. Then megaloblastic anemia due to enhanced metabolism of folic acid. So folic acid supplementation can be given for this, and GIT manifestations like nausea and vomiting. which can be prevented by taking the daily dose in divided portions or even after meals administration or with plenty of water, the molecule can be taken. The miscellaneous like blood dyscrasias, aplastic anemia and agranulocytosis, appearance of Ellis cells and with hemoglobinemia. Rapid IV administration gives rise to the manifestations like the patient may land upon in cardiovascular collapse or severe CNS depression. This is a therapeutic concentration. Then ADR at high plasma concentration, what are they? Nystagmus is the first sign of toxicity or overdose and can be used for dose adjustment. So mild toxicity, the manifestations can be at high dose, mild toxicity. Drowsiness, fatigue, headache, and confusion. Larger doses further going. Vestibulocerebellar syndrome, like the symptoms can be vertigo, ataxia, nystagmus, diplopia, cerebellar atrophy, and dysarthria. Ocular pain with blurring of vision, delusions, hallucinations, and other psychotic episodes. Then cognitive impairment, behavioral changes is the most problematic area that we can say. Then peripheral neuropathy in old people, and these effects are dose related and reversible. Okay. Then ADR on IV administration. Its solution is prepared in polyethylene glycol and used by IV route, giving rise to whenever you inject IV, the manifestations around the area can be local edema, intimal damage, discoloration of skin, blue color, purple blue color, and then cardiac arrhythmias and hypotension. Hypotension and cardiac toxicity specifically may be because of this uh, solvent that is polyethylene glycol, which we use to dissolute to make prepare the solution. Okay. The rapid IV injection can make the patient land upon in cerebellar and vestibular toxicity. So phenytoin is precipitated in glucose, so it is not diluted in 5% dextrose, but in normal saline. And IV injection can give rise to local vascular injury, giving rise to further intimal damage and thrombosis of the vein, giving rise to edema and discoloration of the injected limb. So purple glow, that's what we have discussed earlier. So if the solution, phenytoin solution gets excavated, then it may lead upon, give rise to tissue necrosis also. This is purple glove syndrome. Okay. Distal to the injection site. Then ADR in pregnancy. It is teratogenic molecule giving rise to fetal defects, neurotube defects like spina bifida, because of folic acid deficiency, and fetal hidantine syndrome specifically, more than even that of spina bifida. So the manifestations of the fetal hidantine syndrome are cleft lip, cleft palate, microcephaly, and congenital heart disease. Newborns of mothers who receive phenytoin may develop coagulopathy due to hypoprothrombinemia and hemorrhage. That's what we have discussed earlier also, because of inhibition of vitamin K. So we can supplement vitamin K for such people to prevent these kind of manifestations. So fetal hidantine syndrome, midline hypoplasia, ptosis, wide mouth, inner epicanthic folds, short neck, mild webbing of the neck, short phalanges, hypoplastic nails, congenital heart defects, microcephaly, and mental subnormality. Okay, so congenital heart defects may, and then hypoplastic features of the main things, fetal hidantine syndrome. This is all because of the toxic epoxide metabolite, that is arene oxide metabolite, and also impaired DNA synthesis due to folate deficiency. So altogether we have vitamin K, vitamin D, and folate deficiency because of phenytoin administration. Then, so this is fetal hidantine syndrome, cleft lip, cleft palate, congenital heart disease, slow growth, and mental retardation. Then therapeutic uses. It is used in partial seizures, drug of choice, generalized tonic-clonic seizures, and status epilepticus, that is second choice when compared to fosphenytoin slow IV. Then both phenytoin or fosphenytoin provide a longer duration of seizure control than is provided by a benzodiazepine in the treatment of status epilepticus. So fosphenytoin is more preferred, along with maybe phenytoin also. Contraindicated in petit mal or absent seizures and juvenile myoclonic epilepsy and Dravet syndrome. Dose is 200 to 600 mg daily oral. Non-anti-epileptic uses. See, the non-anti-epileptic uses of anti-epileptic drugs itself is a question, big question for postgraduate students. And the UGs, they may get either a short note or very short note. So trigeminal neuralgia, glossopharyngeal neuralgia, ventricular arrhythmias due to digitalis toxicity, and to enhance wound healing. Drug interactions. Enzyme inhibitors decrease the metabolism of phenytoin. So they increase plasma concentration of phenytoin. That is like cimetidine, chloramphenicol, disulfiram, difumarole, isoniazide, warfarin, etc. Phenytoin competitively inhibits the metabolism of warfarin, also inducing toxicity. Sodium valproate displaces protein-bound phenytoin and inhibits its metabolism, whereas sucralfate inhibits the absorption of phenytoin. Theophylline inhibits the absorption and enhances the metabolism of phenytoin, reduces the concentration of phenytoin. So there is a loss of anti-epileptic effect totally. Carbamazepine and phenytoin are phenobarbital and phenytoin. Carbamazepine and phenytoin one group, or phenobarbital and phenytoin, they increase each other's metabolism. So this here, it is like enzyme inhibitors decreasing the metabolism. They are CDIW, you can remember like that. Whereas inhibiting the metabolism here, the other molecule which inhibits its metabolism is, one is sodium valproate, number two is sucralfate, and theophylline, of course, enhances the metabolism. Drug interactions. Phenytoin induces metabolism and reduces the plasma concentration and the therapeutic efficacy of other drugs like levodopa, corticosteroids, digitoxin, doxycycline, and rifampicin, steroid contraceptive pills, theophylline, etc. Vitamin D and vitamin K. That's why the vitamin D and vitamin K deficiency that we can see with phenytoin. So here you can remember CD, ST. Then here same CD, RST, LCD, RST. Okay, inducing the metabolism here. Inhibiting the metabolism, CD, ST. ST, of course, enhances the metabolism. This is LCD and RST, rifampicin, steroids, and theophylline. Okay. So, phenytoin summary slides. So, we finished the phenytoin molecule. So, just by going through these summary slides, you can write everything about phenytoin. Non-sedative, membrane stabilizing action. These are the 4 points that you have to write. Sodium and calcium channel inhibition. So, apart from that, PTP, post-tetanic potentiation. And then purple glow syndrome, P for phenytoin. So, P for PTP, purple glow syndrome, PPB high, that is plasma protein bind. Mixed order kinetics, enzyme inducer, immediate and extended release preparations are available in USA. Then ADR, 10H, hypertrophy events, hypersensitivity reactions like Stevens-Johnson syndrome, hepatic necrosis, hirsutism, hyperglycemia, hypertrichosis, hematological reactions, hyperproteinuria, hemorrhage because of vitamin K deficiency, hypocalcemia, and osteomalacia because of vitamin D deficiency, and folic acid deficiency. Because why I have, even though it is not H, why I have mentioned is the deficiency of vitamin K, D, and folic acid results. So this is adverse effects H10. You can just remember. So if you go for high dose, you can remember the mnemonic alphabet. Sorry, alphabetical order NOP. So N for nystagmus, O for ocular pains, P for psychotic episodes and peripheral neuropathy, and also vestibulocerebellar syndrome. That is like all CNS manifestations. Then prolonged usage, P for prolonged, P for phenytoin phases, and peripheral neuropathy. Okay, high dose NOP, prolonged usage P for P. Then IV also P, it is polyethylene glycol combination and purple glow syndrome. Pregnancy, fetal hydantoin syndrome, because it belongs to the molecule hydantoin derivatives. Then indicated in partial seizures, contraindicated for petit mal epilepsy. Both P. You can just Like you will not have any confusion if you remember like that. Then that is about phenytoin. Hope you can remember now phenytoin very well. Phosphenytoin, it is a water-soluble prodrug of phenytoin, rapidly converted to phenytoin in the blood within minutes, lower incidence of purple glow syndrome. So better molecule when compared to the phenytoin. Okay. Hypotension and cardiac arrhythmias are also less likely, and it can be used for IV administration in the treatment of status epilepticus, unlike that of the phenytoin molecule. There is no purple glow syndrome here with this. Well absorbed after IM administration, so it is also used for status epilepticus management. And phosphenytoin may be administered intramuscularly, whereas phenytoin sodium can never be because it gets precipitated in the muscles and gives rise to the damage, tissue damage, and pain also. While phenytoin cannot be injected in a drip of glucose solution, phosphenytoin can be injected with both saline and glucose. This is the difference. IV can be given, IM can be given, and can be given along with glucose also. Okay. So differences between phenytoin and phosphenytoin. This is a short note or 2 marks question for UGs. And for PGs, it is bio-OC question. Active drug, prodrug. Slow rate of infusion mixed in propellant glycol, so water soluble. Precipitates in IV solutions, no precipitation. Cardiac arrhythmias, hypotension, more risk, less risk. Extravasation and even purple glow syndrome, fewer tissue side effects. Okay. Then coming to phenobarbital. Oldest anti-epileptic drug, broad spectrum anti-seizure activity except petigma. So even the phenytoin as well as phenobarbital both are contraindicated for petit mal epilepsy. So anti-epileptic activity is similar to that of diphenylhydantoin, but in addition it raises the seizure threshold. Combined with phenytoin in the treatment of resistant grand mal epilepsy, focal cortical seizures, and hips arrhythmia. Dose is 60 to 180 mg in divided doses. Advantages, well tolerated, long half-life, so OD administration. So like that of the phenytoin, which follows saturation or mixed order kinetics, which needs TDM, here TDM is not needed. And it is cost effective. Differs from other barbiturates such as pentobarbital in producing anticonvulsant effect in doses lower than sedative hypnotic dose. That is the main advantage with this molecule. So these are advantages of phenobarbital. Mechanism of action. Low concentration, positive allosteric modulator of GABA A receptors, and high concentration directly activates GABA A receptors. And a therapeutic dose, it binds to the channel modulatory site on the GABA A receptors, which we have discussed in our introduction to CNS GABA receptors. Okay, so modulatory site, it binds to that site and enhances GABA mediated inhibitory effects by increasing the duration of chloride channel opening. Phenobarbital, increasing the duration. Okay, whereas benzodiazepines, they increase the frequency of chloride ion channel opening. That is the main difference. It also inhibits glutamate mediated excitatory effects by blocking AMPA receptors, that is non-NMDA receptors. At higher doses, it blocks L-type calcium channels, not T-type. Okay, L-type calcium channels and use-dependent sodium channels. So what is this here? GABA mediated and glutamate inhibition, sodium channels and calcium channels. All these are involved. In contrast to benzodiazepines, barbiturates increase the mean open duration of the channel. That's what we have discussed just now. So that is the main effect with barbiturates. Oral absorption is slow but complete. Plasma protein binding and tissue binding, including brain, is about 50%. 75% metabolism through CYP2, C9 to C19 and to E1 and excreted unchanged, the remaining part. Enzyme end user, this is also of CYP2A, 2B, 2C, 3A, 6A isoforms, and also glucuronide transferase enzyme. And the half-life is very long. That is the main advantage. OD administration we can give 100 hours. So the steady state is reached there, very small fluctuations in plasma levels and enhancement of metabolism of endogenous substances like vitamin D and folic acid. Dose is 60 to 200 mg divided to BD or TI. ADR are due to enzymatic induction, and because of which they are same as that of phenytoin. No gingival hyperplasia, that is the advantage. No worsening of facial features also, and no hirsutism. But there is a possibility of irritability and hyperexcitability in children. Tolerance and prolonged use and dependence, of course, is less. Teratogenic, like that of even phenytoin. So it is also teratogenic. Large doses can give rise to CNS manifestations like nystagmus, ataxia, agitation, confusion, and irritable behavior in children. And also skin rash like scarlet and morbilliform rash and exfoliated dermatitis. Hypoprothromia, same kind of thing, everything with hemorrhage. If you can learn one thing, other things you can easily write just by remembering the mnemonics. Hypoprothromia with hemorrhage in newborn of mother who have received phenobarbital. So vitamin K we can supplement, and osteomalacia megaloblastic anemia. So because of which we can go for vitamin D and folic acid administration. And you also will be seeing that the frozen shoulder and Dupuytren's contracture with this phenobarbital. Another extra added side effects. Convulsions following phenobarbital withdrawal. So you need to tap up the dose slowly and then release it. So if you want to switch over phenobarbital to phenytoin, switch over, reduce the dose of phenobarbital slowly, and then start adding and increasing the dose of phenytoin, so that the risk of recurrence of convulsions following the withdrawal will not be there. Uses grand mal epilepsy and cortical focal epilepsy, simple partial and complex partial seizures, status epilepticus. So IV route can be used when diazepam or lorazepam and phosphenytoin and phenytoin are not able to control seizures, then you can choose for phenobarbital. Okay. Not effective in absence seizures, same is the case with phenytoin, atonic seizures, and infantile spasms. It's also used, not used for juvenile myoclonic epilepsy, contraindicated in petit mal epilepsy and porphyria, and gradual withdrawal should be done. And methylbarbital and primidone are prodrugs, and their anti-epileptic effect is due to their active metabolite, that is phenobarbital. Primidone is again getting converted into phenobarbital. So the summary slide for phenobarbital is phenobarbital. So you can see longitudinal. P means it is similar to phenytoin. P for contraindication for petit mal epilepsy and porphyria. O for oldest, B for broad spectrum anti-epileptic drug, A for allosteric GABA modulator action, R for rash, B phenobarbital, B, and then I'm just giving the reverse of the letter B, that is D. So barbiturates, that is phenobarbital, increases opening duration of chloride channel. So you should not get confused with that. So that's why I have given this mnemonic. And then D for Dupuytren's contracture. I for ion channel sodium and calcium inhibition, irritability in children. So apart from this, GABA modulation, allosteric GABA modulation. T means T half long, 100 hours, tolerance, teratogenic. Then primidone, another molecule. Anticonvulsant action is similar to phenobarbital, but less potent. Largely abundant because of its high incidence of ADR, and metabolized to phenobarbital and PEMA, that is phenyl ethyl melonomide. Dose is 250 to 500 mg VD oral. ADR are same. Apart from that, the miscellaneous side effects also you will be seeing. And uses grand mal seizures, partial seizures as adjuvant or with phenytoin or carbamazepine. Then myoclonic seizures, but not preferred due to mental changes. This molecule is for psychosis. That's why we are not using this molecule at all. It is also used in the treatment of essential tremors resistant to propranolol. So summary slide of primidone. Metabolites, that is phenobarbital and PEMA, and dreadful side of it, not dreadful, we can say it is like discomfort creating side effect, that is like psychosis. So because of which the drug is not used nowadays, and it is also used for propranolol resistant tremors. P for metabolites, psychosis, and then propranolol resistant tremors. Then carbamazepine, another molecule. It's a tricyclic immunostimulant compound with structural resemblance to antidepressant imipramine. Okay. So when compared to phenytoin, there is less cognitive impairment. And it also has lithium-like therapeutic effects, so used in mania and bipolar mood disorders. Carbamazepine have many therapeutic indications. So it is very, very important molecule. Next to phenytoin, this is the most important molecule. It also has antidiuretic action, probably by enhancing ADH action on renal tubules. Similar to phenytoin, it limits the repetitive firing of excitatory neurons by slowing the rate of recovery. That is like a membrane stabilizing action, so nothing to discuss about it. Oral absorption slow, giving the drug after meal helps the patients to tolerate 100% bioavailability. Distributed in brain, liver, and kidneys, and metabolized by hydroxylation and conjugation to 10-11 epoxy carbamazepine. Okay, so this is the metabolite which you need to remember. So this is inactivated by glucuronidation, excretion through urine, and it is a hepatic microsomal enzyme inducer like that of phenytoin. Okay, so it inhibits its own metabolism as well as the other drugs' metabolism also. And valproate inhibits its metabolism. And then the main, we can say, featured with this molecule is auto-induction, because of which the plasma half-life, which is 20 to 40 hours in the beginning, can get reduced to 10 to 20 hours because of auto-induction of metabolism. Then we have extended release formulations. Then acute toxicity can give rise to respiratory depression, stupor, coma, convulsions, and CV collapse. Long-term usage, the patient may exhibit nausea, vomiting, miscellaneous effects like drowsiness, vertigo, ataxia. But diplopia and blurred vision, eye is involved here. High doses, vomiting, diarrhea, and worsening of seizures. Convulsions, it may induce carbamazepine for convulsions. Use of extended release oral tablets helps to avoid high peaks in plasma concentration and the resultant neurologic symptoms. Tolerance is seen hepatic and pancreatic abnormalities, hyponatremia because of antidiuretic effect. Then allergic reactions like rashes and fever. Then idiosyncratic reactions like blood dysplasia, aplastic anemia, leukopenia, hepatitis SLE. Rare but toxic effects, obstructive jaundice, peripheral neuritis, and then other blood dysplasias, and benign leukopenia. This is more specific for this carbamazepine molecule. Okay. Then loss of physical and mental drive can be so gradual that the patient and family, they may wrongly attribute it to the normal process of aging. Maybe because the patient is becoming older, they may think maybe because of this that there is loss of physical and mental drive, but this molecule itself produces those manifestations. When compared to the phenytoin, it is like a minor teratogen, so it can induce only fingernail hypoplasia, craniofacial defects, and delayed development of fetus. But given a chance, see, there is not even a single anti-epileptic drug which is devoid of teratogenicity. So whenever the anti-epileptic drug usage is mandatory for any pregnant lady, we can choose a molecule like less teratogenic molecule like carbamazepine. So dose, we can start with 100 mg BD, and for epilepsy, we can go up to maximum 1200 mg, whereas in neuralgias for up to 400 to 800 mg. Drug of choice in partial and generalized tonic-clonic seizures, and also psychomotor or temporal lobe epilepsy, but contraindicated in absent seizures. Same is the case on the three molecules, contraindicated in absent seizures. Non-anti-epileptic uses. See, so many non-anti-epileptic uses of carbamazepine molecule out there. So you may get even short note also uses. So trigeminal neuralgia, glossopharyngeal neuralgia, post-herpetic neuralgia, differentiation pain in diabetic neuropathy. So all these are like 4 types of pains you can remember. Okay. Then mania depressive psychosis. This is very peculiar to this molecule. Along with that, mood stabilizing action in treating bipolar disorder, and also as an adjunct in the treatment of drug-resistant schizophrenia, and treatment of alcohol withdrawal syndrome, and then diabetes insipidus of central and diabetic neuropathy. Drug interactions, phenytoin and carbamazepine decrease the concentration of each other as both are potent enzyme inducers, whereas carbamazepine decreases the concentration of sodium valproate and erythromycin, INH, fluoxetine, cimetidine, and propoxyphene increase the concentration of carbamazepine by inhibiting the metabolism. Lamotrigine increases concentration of 10,11 epoxide, that is metabolite of carbamazepine, and may lead to toxicity. Drug interactions, serotonin syndrome, when it is used along with MAVA inhibitors, and no clinically significant drug displacement reactions occur with carbamazepine. Being enzyme inducer, it reduces the plasma concentration of haloperidol and oral contraceptives. If you remember which one is enzyme inducer, which one is enzyme inhibitor, you can write down the other reactions, drug interactions. Drug interactions are very, very important regarding anti-epileptic drugs. Okay. Then carbamazepine summary. So carbamazepine, C for less cognitive impairment, but it also gives rise to convergence in CV collapse. A for antidiuretic action and autoinduction. R for respiratory depression, rash used in resistant schizophrenia. B for blurred vision and benign leukopenia. A for alcohol withdrawal syndrome usage, but not used in absence seizure, another E. And MA used in mania, mood stabilizer, minor teratocin, and loss of mental and physical drive. Z for enzyme inducer. E for epoxy carbamazepine, and that is metabolite that we get through metabolism. And extended release formulations are available. And P for used in partial seizures, psychomotor epilepsy, and all sorts of pains like trigeminal, glossopharyngeal, post-herpetic neuralgias, deafferentiation pain, and diabetic neuropathy, etc. And INE means it is similar to the structure of the molecule is similar to imipramine. That oxcarbazepine, a prodrug with similar activity and therapeutic uses as carbamazepine, more expensive. And blockade of sodium, voltage-gated sodium channels is the main mechanism of action. So it gets converted into carbazepine, which acts by similar mechanism like that of the carbamazepine. Mild enzyme induces, so drug interactions are less. Therapeutic profile is similar to that of carbamazepine, but toxic profile is better than carbamazepine. So less hepatotoxicity, less hypersensitivity, hyponatremia, no cross-reactivity with carbamazepine. Drug interactions reduces the plasma levels of steroids, including oral contraceptives. So efficacy is lost, but it does not alter the concentration of warfarin. Uses monotherapy or as an adjuvant for partial seizures in children and trigeminal neuralgia. Same, this molecule is also used, both carbamazepine and oxcarbazepine. And it exaggerates myoclonic absence and atonic seizures, not effective in all cases of mania, though it belongs to carbamazepine. So that molecule is most prominent. Dose is 600 mg orally BD, 2 divided doses up to 2400 mg daily. Eslicarbazepine. This is active metabolite of again oxcarbazepine. Carbamazepine, oxcarbazepine, eslicarbazepine, metabolite of next molecule, earlier molecule. As enantiomer prodrug is very rapidly converted in liver to the same active metabolite as is oxcarbazepine. So undergoes glucuronate conjugation, excreted in urine, no abaxoid formation, so no toxicity because of which. Spectrum of activity is similar to carbamazepine. Failure of oral contraceptives because of the enzyme induction, even if it is little less. ADR's most common side effects, along with the diplopia and headache and psychiatric side effects, hyponatremia, they occur but very rarely. Used as adjuvant in partial seizures with or without secondary generalized seizures and trigeminal neuralgia. Same. Carbamazepine, oxcarbazepine, eslicarbazepine, all are used in trigeminal neuralgia. Here the dose is 400 to 1200 mg oral only. Then ethosuximide. So we have finished phenytoin, phenobarbital, carbamazepine and its derivatives. Now comes ethosuximide. This belongs to the succinimide group of anticonvulsants. It is a pure petit mal drug, most commonly used as a drug of choice for absence seizures. So petit mal we have discussed. So petit mal, E for ethosuximide, and T is sounding petit double. So it inhibits T-type calcium channels. Okay, so that is the main mechanism of action of this molecule. We can see here. The T-type calcium channels are inhibited, so there is no flow of calcium ions, both ethosuximide and valproate also acts on this. Pharmacokinetics completely absorbed from GIT, 75% metabolism by same hydroxylation and glucuronidation. It follows first order elimination kinetics. Ethosuximide does not induce liver enzymes, so TDM is not needed. ADR, all most common side effects, and non-dose related idiosyncratic adverse effects like skin rash, fever, eosinophilia, etc. And rare manifestations like allergic reactions and blood dysplasias, and tolerance on regular use. Then agitation, all CNS manifestations like agitation, anorexia, aggressiveness, restlessness, and inability to concentrate may occur in patients with history of psychiatric illness. No hepatic or renal damage, lesser teratogenic molecule like that of carbamazepine. Ethosuximide is also lesser teratogenic, so it can be preferred in pregnancy. It increases, sodium valproate increases the concentration of ethosuximide by inhibiting its metabolism. Uses as monotherapy in generalized tonic-clonic seizures, but valproate is preferred molecule when combined with ethosuximide. Then used for the only for the treatment of absence seizures. All earlier molecules we have said that all those drugs are contraindicated in petit mal epilepsy or absence seizures, but this is ethosuximide is the pure petit mal drug only used for the absence seizures, but it can also be used for myoclonic seizures. Okay, so it is the main advantage of this molecule is it is preferred in children less than 2 years of age, where sodium valproate is avoided because of its higher risk of hepatotoxicity, sodium valproate. Okay, dose 250 mg per day to start with, and again weekly increasing the dose. Ethosuximide summary, pure petit mal drug, inhibition of T-type calcium channels, first order elimination kinetics, lesser teratogenic. Okay, then sodium valproate. It is a first line broad spectrum anti-seizure drug. Okay, protection against many seizure attacks, little sedation or other central effects. Mechanism of action, it is broad spectrum. So broad spectrum of different kinds of mechanisms of action over there. So it produces phenotonic-like activity by sodium channel inactivation or membrane stabilization. And it produces ethosuximide-like activity by blocking calcium channels, T-type calcium channels. Then GABA mechanism, varied mechanisms are there. Increasing GABA concentration by inhibiting the degradation or metabolism, by inhibiting the gamma transaminase enzyme, and increasing the synthesis by stimulating glutamic acid decarboxylase. One is degradation is reduced, synthesis is increased of GABA, and blockade of NMDA glutamate receptor activity. So sodium channel, calcium channel, GABA, and glutamate. Pharmacokinetics, well absorbed orally, food release absorption, bioavailability 100% and 90 to 95% bound to plasma proteins. So because of plasma protein binding property and its enzyme inhibiting action, so many drug interactions we can expect. It is an enzyme inhibitor. Till now we were discussing about enzyme inducer, but this is valproate is enzyme inhibitor. And can inhibit its own metabolism and also of other drugs. Metabolism by oxidation and glucuronidase conjugation excreted in urine. And we can have extended release formulations also. Inhibitor of hepatic macrosomal enzymes. So inhibits the metabolism of lamotrigine, phenobarbital, phenytoin, carbamazepine, and also all the other drugs. So apart from that, it interferes with conversion of ammonia to urea. So it can cause, because of which it can cause like a fatal hyperammonemia. Ammonium is not going to get converted to urea, so ammonia concentration increases. Fatal hyperammonemic encephalopathy because of enhanced ammonia concentrations in the blood. So because of this, drug is contraindicated in these patients. It also gives rise to predominantly weight gain, apart from that other common side effects, and also fatal hepatotoxic molecule. Okay, risk is greater in children less than 3 years. That's why we don't advise sodium valproate for children specifically. So rather we can go for the other molecules. L-carnitine may be tried if signs of hepatotoxicity appear, and other idiosyncratic reactions also can happen. And most teratogenic. So it gives rise to spina bifida. Phenytoin gives rise to most predominantly fetal hidradine syndrome, whereas sodium valproate gives rise to most predominantly spina bifida. Okay, contraindicated in hepatic porphyria. Withdrawal seizures can give rise to 300 mg PD orally the dose. So spina bifida. So this is not closed. Incomplete closure of the embryonic neural tube. So this is like spina bifida. So anti-epileptic uses, where it is used. It is a broad spectrum molecule. So generalized tonic-clonic seizures drug of choice, absence seizures also drug of choice, both the things. Apart from that, it is also used in the management of atonic seizures, partial seizures, prophylactic and febrile convulsions, myoclonic seizures, and then status epilepticus IV formulations we can go for, and then Lennox, Gustave syndrome, and infantile spasms also it is drug of choice. Non-anti-epileptic uses, trigeminal neuralgia, tardive dyskinesia due to its GABAergic action, and to reduce cortisol secretion in the management of Cushing syndrome, along with meterapine, it can be given. These are all non-anti-epileptic uses. So trigeminal neuralgia management. So this is a very, very important question for postgraduate students. So all these drugs that you have to give. Drug interactions, not a CNS depression, but potentiates the CNS depressant effects of phenobarbital and benzodiazepines. Increases plasma levels of phenobarbital and lamotrigine by inhibiting their metabolism. Inhibits hydrolysis of active epoxide metabolite of carbamazepine. Displaces phenytoin from protein binding site and decreases its metabolism. So phenytoin toxicity may occur. And along with clonazepam, this valproate is contraindicated because of absence status may be precipitate. Okay. Summary: first-line broad-spectrum anti-seizure drug, little sedation, inhibition of sodium and T-type calcium channels, potent enzyme inhibitor, extended-release formulations, fatal hyperammonemic encephalopathy, weight gain, fatal hepatotoxicity, most prominent idea, most teratogenic, giving rise to spina bifida and neural tube defects. Then it's similar kind of molecule. It's a combination of divalproate. Sodium is combination of valproic acid and sodium valproate in equal amount, 1:1 ratio. Advantage is slow absorption, less GI and CNS side effects. So uses, it is most commonly used in migraine prophylaxis, similar to sodium valproate, such as epilepsy, yeah, but mainly used for mania. So both the conditions it is used, but mostly for mania. So we have enteric coated preparations and slow release preparations also. So enteric coated preparation is used mainly for maniac depressive bipolar disorder and migraine prophylaxis also. 500 mg BD. Then the last group of molecules are benzodiazepines. They're not a good choice for the long-term management of epilepsy because this is 2 marks question for UGs. And for PGs, it is YOC. They're not used for long-term management of epilepsy. The reasons, what are the reasons? Number one, tolerance can develop. Then drowsiness and ataxia may be there. And in children, there is a possibility of paradoxical hyperactivity. And on abrupt withdrawal, there is a risk of status epilepticus, which is difficult to treat. Then mechanism of action, enhance the frequency of GABA-mediated chloride channel opening. Barbiturates, duration, here the benzodiazepines frequency. Apart from that, positive allosteric modulation of GABA A receptors. They increase the effectiveness of inhibitory neurotransmitter GABA. High doses, they also block sodium channels. So used in the management of generalized status epilepticus. Uses first-line acute treatment for seizures either in status epilepticus or seizure clusters. The seizure clusters we will discuss in pharmacotherapy again. So mechanism of action, barbiturates or benzodiazepines, GABA receptor mediated action at allosteric sites facilitates GABA action. Barbiturates enhance the duration, whereas benzodiazepines enhance the frequency of opening the fluoride channel, hyperpolarization, giving rise to CNS depressant activity. Then diazepam. So few molecules are there under benzodiazepines. So we'll discuss that and we'll end the session. Diazepam. So this molecule has high lipid solubility, very rapid onset of action. Thrombophlebitis, marked fall in BP, and respiratory depression are the most common areas. So it has to be given, or whenever we give IV, it has to be given very slow IV, otherwise the patient may die. Okay. Then uses first line drug for emergency control of convulsions, status epilepticus, tetanus, eclampsia, convulsion drug poisoning, etc. Life saving in status epilepticus as well as non-epileptic seizures also. And for local anesthetic induced seizures, we can give IV administration. And the other routes of administration of diazepam, apart from slow IV, are rectal instillation of diazepam for febrile convulsions in children. So that is the easiest way for children. And then rectal gel formulations for acute repetitive seizures or seizure clusters. So this is one molecule where we have the new route of drug administration among all the AEDs, that is rectal administration of diazepam for seizure clusters and febrile convulsions in children. Then comes lorazepam molecule. L for lower lipid solubility, slower redistribution, less effect on BP and respiration, and low risk of thrombophlebitis. So long-acting molecule, that is the main advantage. That's why it is preferred over diazepam. First choice of drug for the treatment of status epilepticus, even when compared to diazepam, it is more better than diazepam. So 4 mg IV. Then clonazepam, more potent and longer acting than diazepam. Potentiates GABA-induced chloride influx to produce sedation. C for chloride ion channels inhibition. Then potentiates GABA-induced chloride channel influx to produce sedation. Okay. Well absorbed orally, 85% plasma protein binding, half-life is 24 hours, long-acting, so OD administration. Inactive metabolites in the liver, excretion through urine. ADR, serious ADR like neurological, drowsiness, ataxia, personality changes, slurred speech. All these are dose related. Apart from that, irritability, difficulty in concentration, behavioral abnormalities, all these things can be seen. Skin eruption and blood dysplasias, respiratory depression. Uses petit mal epilepsy, second line drug, next to ethosuximide and sodium valproate. Adjuvant in myoclonic and akinetic seizures and infantile spasms. All sorts of epilepsy we can use this clonazepam. Adjuvant of phenobarbital and phenytoin in the treatment of resistant grand mal epilepsy, alternative to lorazepam or diazepam in status epilepticus. For acute mania also we can use an intranasal spray, that is the orphan status that we can have for recurrent acute seizure. That is diazepam, we have rectal administration, intranasal administration, clonazepam. Dose is 0.5 to 5 mg TDS. Then comes clobazam. Action by GABA action facilitation and positive allosteric modulator of GABA A receptors, bioavailability 90%, half-life is 18 hours. But an active metabolite increases the half-life up to 35 hours. Metabolized in the liver to major metabolite desmethylclobazam or norclobazam. That's the main metabolite which produces anti-epileptic action. It is a moderate inhibitor of CYP2 disease. Similarly, kind of drug interactions can be seen with the other enzyme inhibitors. ADR similar to other benzodiazepines, dose-dependent side effects like somnolence, all sorts of CNS manifestations, sedation, disorder, ruling behavioral changes, including aggression. Then less sedation, psychomotor effects, tolerance is seen with this molecule also. Withdrawal symptoms occur. And then the main advantage is it does not interact with other anti-epileptic drugs. Uses partial and secondary generalized epilepsy, petit mal, atonic, and refractory epilepsy. Used as adjuvant with older anti-epileptic drugs in refractory cases, and seizures associated with Lennox-Gastaut syndrome. Dose is 10 to 20 mg. Non-clobazam has anti-seizure activity, although it is weaker than clobazam. So LG syndrome, only this molecule we use. Then other benzodiazepines, nitrazepam, So drowsiness and lethargy are common side effects used in infantile spasms, myoclonic seizures, and focal seizures. Clozapine is used as adjunct drug for the treatment of complex partial seizures, childhood myoclonic epilepsy, and complex partial seizures. Okay. So with this, we end this second session about conventional anti-epileptic drugs. This is over. Now the third session will be on newer anti-epileptic drugs, and the fourth will be on prescribing guidelines and the pharmacotherapy of various sorts of epilepsy, including pregnancy and epilepsy and resistant epilepsy management. All these I'll be discussing in the fourth session. So two more very short sessions are there, so that I'll try to upload as early as possible. Thank you. Thank you, one and all. If you have any doubts, you can get back. Hope these mnemonics and summary slides will help you a lot, because anti-epileptic drugs, it is like so many drugs and so many manifestations are there regarding ADR, so many points to remember regarding the pharmacokinetics, therapeutics, and everything. So I took a little bit more time in preparing and making the topic as palatable and as easy for all of you. Okay, thank you. Thank you, Anand.